Thanks very much, Malcolm and colleagues, for inviting me up this afternoon. It's a real genuine pleasure to come and talk about some of the challenging issues that we all face. I must confess, when I arrived here, I wasn't quite sure who I was going to meet, but I was delighted that within about 5 minutes, the first two people that I met were two Glaswegians. So I thought, well, at least two people will be able to understand what I say, and they can also do a bit of dissemination and spread it. So got a couple of translators in the audience. Before I start to talk about UCL Partners and some of the work that we're involved in, I thought I'd start with a parable or metaphor. So I don't know if anyone knows the story behind this bridge, the Choluteca Bridge in Honduras, which was built by the American Army Engineering Corps just before the Second World War. It was a pivotal transport link between two cities in Honduras. And of course, one of the problems about that area of Central America is it's plagued by hurricanes. And what would happen periodically is hurricanes would happen and this bridge would essentially be knocked down. So in the mid-90s, the Honduras government reached out to what was probably one of the most leading Japanese engineering companies in the world to design a bridge that would survive any hurricanes. And the company spent 2 years building this bridge, which, in fact, when you start to look through some of the historical brochures, they publicized as the indestructible bridge. And indeed, that in some senses, that was true. What happened in 1998, some people might remember, was a huge hurricane, Hurricane Mitch, level 5 hurricane, which demolished parts of Honduras. And as the engineering company had promised, this bridge survived. But the problem was that the conditions that resulted from this meant that both the roads and the direction of travel of the river changed so that the bridge became redundant. And I think in some ways this is a fantastic metaphor, both for what's happening in healthcare in terms of how the direction of travel is changing so enormously. And we have these rigid structures that are probably not in the best position to accommodate the change, and arguably for our industry colleagues about how one deals with competitors that are coming along with disruptive innovations. So on that background, UCL Partners was set up by Sir David Fish 10 years ago this year. And what it really did initially was to try and bring together competitive organizations within quite a small area of north central London. And as Malcolm said, concentrated on what were regarded at that time as insoluble problems, such as reconfiguring stroke services, and had some very early successes around how you could do that. And as I was saying to Patrick earlier on, the most important thing is that we put a strong case to factor in the evidence generation around that, which is fundamentally important in terms of sustainability of models. And I don't think, particularly at this point in time, we continue to always do that. Our organisation has grown, and we now cover a population of 6 million, with about half of our population inside London, half outside. And we work with a lot of higher education institutes. Our name is slightly misleading because we have many organisations that bring many other strengths. Of course, UCL is a fantastic organisation, but we work with many other organisations, QMUL, City, London School of Hygiene, Tropical Medicine. And we have a very strong connection to our health system with regular meetings with our chief execs and academic leaders that gives us some legitimacy in terms of when we try to take change forward and develop partnerships, either with the health system, with academia, or with industry, that we have some traction within population bases to try and both experiment and then scale some of those. Our model is different. Clearly, in centres like Cambridge, where there is an amalgamation of huge assets, we have taken a very proactive approach to bringing together a number of different functions. It began, as many of you know, with the designation of academic health science centres 10 years ago, and they're now coming towards the end of the second 5-year licence cycle. And the academic health science networks, which were established just over 5 years ago, act as a mechanism to link to that population, to look about how you can transform lives through innovation, to look at economic growth, and also how you can look at areas around improving outcomes in healthcare in many different ways, but I think quite often by reducing unwarranted variation. But that link that I mentioned earlier on in terms of the research and the evidence generation is really important. And so our linkage to our clinical research network, our CLARC about to become ARCs, which at least most people will remember the acronym, Applied Research Collaboratives, and the Genomic Medicine Centre, we see as important mechanisms and routes for doing different things and bringing together these community of interest, because these are difficult problems and you really need a large number of people from different backgrounds and expertise to deliver on them. I think what's been quite helpful in terms of trying to catalyse how we develop new approaches to healthcare and how we scale it and how we take the best innovation and get it out to the people who need it most effectively has been helped by the life sciences industrial strategy that Malcolm alluded to a little bit earlier. And I think that is important at times to have roadmaps, particularly when there are challenging times for economies and countries. And I think everyone here would recognise that this is probably the most challenging time that we've faced in most of our working lives. So how do we get past that to try and think about other solutions, not just for what's happening locally at sort of a political level, but getting back to the point I made with my metaphor earlier on, there are significant challenges around people living longer, but not necessarily healthier. And the implications to health systems and economies is so worrying that we really need to think about new ways of doing things quickly and at scale. And some of the moves about how we can try to create better industry connectivity, I think have been really helpful. And I know Cambridge has been very much involved in these discussions. So a number of the notifications coming out of the second sector deal that was published not too long ago, I think will be very, very helpful. And we've been working with some of the companies around that as well. The Accelerated Access Review has been part of the industrial strategy, and that was George Freeman, one of the previous life sciences ministers. I think very reasonable vision to identify good stuff that you can get out there quickly. And we at UCL Partners, and we're a very proud and active member of the networks for the 15 academic health science networks, and so it's great to have Piers and Steve Feast here. See that as a very good pathway for us working with the system to identify things that need to be spread because they have demonstrated effective clinical outcomes. They have demonstrated that they can provide a return of investment to the system. And that focus on financial benefits, I think, is really important. And as a clinician, where you were almost told, well, you don't have to worry about the finances. If you think you've got a good idea, you need your patient to have 5 MRI scans, why not go ahead and do it? Those days, I think, have to change. The use of resources, we have to be much more, to use a Gordon Brown phrase, prudent with. So the other thing that I hope we get a chance to talk about collectively now, which again is an output that's been generated through the life sciences industrial strategy led by John Bell, is this idea around digital innovation hubs. And Andrew Morris, who was Chief Scientific Officer in Scotland and in fact was our informatics director at UCLP, now leads this initiative, which I think really has a very exciting prospect of how we bring together that sort of triangulation between the health system. And when I say health system, despite working in an acute setting for 33 years, I'm very much invested in a much broader health and social care system, but how we bring that together with academia. And again, with academia, it's not just about the discovery science, it's about the research and evidence generation throughout the system and how we start to expand into areas that are not researched, and working with industry partners, both large and small. And first of all, we have to get people aligned around various missions that we see as important. But of course, there are great challenges about these things, and where I think some of our systems are useful is in terms of that brokering, that convening, that acting as a genuine need to bring people who may not have come together before, who have looked at the world in different ways, and trying to take these agendas forward. And that's what I find exciting and hopefully beneficial. So we're, like I'm sure many people here, are in discussions about, what are some of the models that digital innovation hubs might look like. And we've been working with Andrew Morris and his team, and we'll be involved in running out some roadshows over the next couple of months across the United Kingdom about looking at some potential capabilities and features that they might start to offer. When I presented this talk, I sent the slides to Malcolm, who promptly cut them in half, which was probably a good thing because there's a lot to talk about, so I think it's good to be focused. But I was actually going to talk for quite a long time about context setting and understanding the problems. I think there is huge value in understanding what it is you're trying to do before you start talking about, what the answers to that are. So I've had to skip a lot of the challenges, but I think the capability gap is certainly one of the big ones. And the reason that I put it up here is that I think there is a huge potential for how we start to work with industry, where we can start to work about both how developing mechanisms where you have appropriate access to data and cohorts, and we have appropriate access to capability around things that I think, frankly, we don't have the expertise or the funding to do on our own. So we need to get those things right. The academic health science networks, which as I said, were established about 6 years ago. I think one of the biggest strengths of them is that they cover the whole of the country, because I think one of the things that we have a duty and responsibility about is equitability here. As much as it's fine for us to have academic centres of excellence, the risk is that the dissemination of knowledge and the translation of that doesn't permeate through the system in a way that's fair. And even with digital transformation, there is still the risk around exclusion and isolation of populations. And I think one of the strengths that the HSNs have shown is that they do have the potential to identify best practice, best innovation, and then create a mechanism for spread. And those mechanisms for spread, which actually industry, particularly big industry, have often been very successful at, in terms of how they can prototype rapidly but have distribution chains that can get things out quickly. We have to develop our own systems, but you have to have coverage to allow that to happen in a way that's fair. And once you start to do that, then you can then start to look at some of the infrastructure for how you can scope some of the best solutions that are coming both from industry but from within the health and academic systems itself. And I think, the East of England HSN, which has hosted the Small Business Research Initiative around funding, its earlier phase innovation, and then, if successful, giving more impetus to that, I think has been really, really important. That's one of the things that the HSNs, I think, have taken on really well. But what they've also demonstrated, which I think was absolutely necessary, was to show both an impact in terms of the population reach, how they can work with a large number of industry partners, and then also the effect that they can have on economic growth, both for those industry partners, but for the UK itself. And I think as partners of the HSN, we've been able to demonstrate that. It's not easy, of course, because one is always going to be having to deal with a spectrum of behaviours and different appetites for risk, and we have that in our own lives. My clinical colleagues, half of them are, probably more than half actually, are nervous and slow to start thinking about how they can interact with artificial intelligence, technological solutions. There'll always be people that are ahead of the curve. Our job is to try and be transparent and provide evidence so that people can shift along that curve as quickly as possible. I think one of the exciting things which provides a great opportunity around this the sweet spot between industry, research, and the NHS system is through the Accelerated Access Collaborative, the commissioning of the HSNs to create innovation exchanges. And they are now already across the 15 regions starting to do a number of important roles. Firstly, what they do is that they help to identify the greatest needs. And, you know, that means that there has to be engagement with patients and populations in the health system, and also a balance about what the health outcomes and the financial benefits of that are. And then having done that, trying to create communities that signpost so that industry partners know who to go to for the right advice, know who to go to have conversations about appropriate access to data. And clinicians can develop the skills and the connections to other people within the health system or industry about trying to change. And I think in terms of one of the big challenges that, of course, that we have currently is in the workforce gap, but also in the workforce capability gap. And how do we set up programs that are training people to be fit for purpose for what future healthcare is going to look like? Because it's not going to look like how it operates now, where we're still the sort of biggest users of fax systems in the world. The other aspect of the Accelerated Access review was the creation of bringing together centralised bodies who could look at products that had a very clear evidence base for benefit and cost effectiveness, and then use the mechanisms that they had to have rapid uptake for those. And we see that as potentially important. I think it's still very early days, but we were really pleased with one of the products. And I'm a neurologist, which although people talk about neurology as being it's a really interesting subject, it's very much a Cinderella subject. I mean, once you've sort of mentioned Parkinson's disease, migraine, epilepsy, multiple sclerosis, nobody can name any of the other neurological conditions. I mean, they're really sort of marginalised. So we need to get better publicity, and we were delighted that one of the products that we helped develop from the discovery science side, which was repurposing a drug that was used for hairy cell leukemia, and actually was initially rejected by the FDA because of a potential cancer correlation. And our researchers did a Freedom of Information Act, managed to get the data across the world, show that was artifactual, and then show from further studies and real-world evidence. And on that basis, this drug is now ready for rapid uptake through the Accelerated Access Collaborative. I think data and informatics will be one of the major keys that allows things to happen effectively. Yes, it's challenging, and we can spend the whole of the session talking about the governance challenges, the consent problems, the nervousness of patients. Absolutely, all very, very legitimate areas of concern that absolutely need to be tackled. But if you can have case studies where you can demonstrate that you can start to use data which is changing people's lives, and then you get the legitimacy to bring people together, that will be one of the keys that allows us to work and to link data sets, both within the NHS, within academia, and to work with industry. And one of the national initiatives, the local healthcare record exemplars, we've worked very closely, and we decided to be really ambitious, where we tried to work to essentially bring the whole of London together around an agreement about data sharing across the whole health and social care system. Now, having worked in London for over 30 years, I never thought I would ever see that happen in my lifetime because of the tribalism that happens in healthcare. But actually the leadership, which again I'm really proud to say came from our partnership within East London, has demonstrated that we can bring London together. And I think that where that's going to start being really useful is that we can then start to link that up with an academic mission, so the creation of the Health Data Research UK hubs, of which obviously Cambridge is one, will be a great way of providing some of that infrastructure about data linkage. And I think that is likely to be a very important mechanism that then links into the digital innovation hubs. And in our local healthcare record exemplar system, which is still in the setup phase, and trying to get data to flow appropriately. But we think that within UCL Partners, because we've developed a very good relationship with industry, and I'll give some examples shortly, Malcolm, don't worry, it is a mechanism to link these things to what we're doing with industry partners. We see that as one of the mechanisms to do that. So one of the ways that we think that we're going to do that is that Ara Darcy did a London Health Commission about 3 or 4 years ago, and one of his recommendations was in setting up a virtual system that essentially allowed people to come together as a community of interest around digital health. And the 3 London Academic Health Science networks, together with the 3 London Academic Health Science centres, have come together and are doing that. And we've set up a very successful digital health accelerator, which is now supported around about 90 companies, actually, and is now being scaled out across other parts of England. It's also been a really good mechanism for international collaboration. I think we do sometimes tend to internalise and focus on, are we competing against centres within England? No, we're not. We're competing against the Bostons and Singapores and China's, and so we have to start working with other international groups. So we've set up a collaboration with IBM and got some philanthropy funding to identify life sciences companies from Israel that we will then are now starting to bring across into the UK. But actually, as much as that's really quite exciting, when you start to go out and work with other systems, what you see there is their ability to work across sectors far better than we do in this country. And so the ability to work cross sectors, I think, is an opportunity that somewhere like Cambridge clearly has. So we have been very proactive about certainly trying to build up that community of interest. And in this example, quite a lot of them are with SMEs, but SME description covers a vast difference in scale. So sometimes that is an individual who's pretty much got an idea and has set up a name, to companies that are remarkably well financed and who can compete at international levels. And one of the things that we've done where I think there's great scope to develop is what we're calling an evidence generator, which is essentially to create a registry of interest of academics across our partnership, and then start linking that expertise to some of the needs of the industry partners, and particularly for SMEs where they come in and they don't have necessarily a lot of funding, for them to get that research and evidence generation, and also the cashier being linked to a good university or an academic health system is remarkably helpful. Personally, I think that this model could be expanded, because we're approached quite often by people who are developing things within the NHS but don't have the expertise or know where to go. I mean, if you try to navigate an organisation like UCL, good luck. It's a vast organisation. So we need to think about ways that we can try to link up within our own academic organisations. But we do work with other companies, trying to get them to focus on significant needs. And Google DeepMind, who have been I think really a remarkable organisation in terms of how they are using artificial intelligence and machine learning. And it was interesting because, as many of you know, one of the first collaborations that they did was with the Royal Free Hospital, not actually around any clever machine learning algorithm. It was really just a sort of notification system for patients with acute kidney injury. But in going fast and breaking things, you can sometimes get into significant problems because you're not taking into account the consent and use of people's data, which we have to be able to sort out. But actually, that situation, which was not a good situation, led to other collaborations and much more mindful use of data. And the Google DeepMind example at Moorfields, which I think I may reference a bit later on, it really has the potential to be transformational around early diagnosis of retinal disease in a way that can overcome significant problems for the system, because that expertise is essentially made available to people anywhere in the country. We as our system, and it may be my prejudice and bias being a clinician, but I'm really excited about industry collaborations where we can help try to identify how we improve how the system operates. And this was a collaboration that we set up about 2 years ago with Celgene, where they wanted to identify people interested in creating new models of care for dermatology pathways. And because we were essentially managing and brokering this, we were able to factor in not only that they could provide a new model that would benefit patients, but that they were collecting the evidence and working with Celgene collaboratively. And I think models like that is something that we would be keen to do more of. We're like here, we're very, very blessed with the discovery science assets we have. And so, many of our clinical academics are coming up with ideas and discoveries which have the potential to transform millions of lives. And what we have to do is that challenge about how we can identify those, support them through the gaps in funding or the translational difficulties. And there are a couple of examples which have are managing to break through there. But when companies come to us, what we're quite keen to do is then reach out to parts of our system that might not necessarily get all the opportunities. It's reasonably easy to work with the University College London's or the Royal Frees or the Addenbrooke's. This was an opportunity in a recent call for the Space Agency funding around use of 5G satellite technology. And what we were able to do was to take this out to Southend, to a hospital, a district general hospital, who actually had the vision to working with researchers to put a scanner into an ambulance. Now that's not particularly scalable for managing all the strokes in Essex, but what you can start to do is how can you start to use that technology for identifying problems in a pathway and then use the learning from that to scale. And so we've put in this bid with a number of SMEs around that. Just coming back to the Google DeepMind example, I mean, this was where they were able to look at a roughly around 1,000 training data sets, and then using machine learning to quite rapidly develop a system which I think is important, because I think there's a really important discussion to be had about what is the evidence basis that we're using around digital technologies. And we need some companies to be setting the bar and the standards with the robustness of this. And this paper published in Nature Medicine, I think, absolutely set that bar. But what's interesting is as you start to understand much more about these collaborations, you start to recognize some of the difficulties. The amount of data cleansing that needed to be done to make this data actually useful to the system was enormous. I don't think that there's any health system that could have invested the amount of money to actually have done that on their own. And so it raises a number of problems for me. I think a fundamental problem that we've failed to address is the quality of data that we collect and code within the NHS. And if you're collecting rubbish, then you're never going to get good stuff generating. So, we can't retrofit it all by getting companies to spend 10, 20 million pounds. Is there a way of trying to do this better? Other companies that we've worked with often start to go out and identify academic systems that they can start to get a sufficient level of evidence. And Sleepio, who are quite an innovative company, had connected up with academics in Oxford and have done very impressive randomized controlled trial in the digital space. But what we're seeing from commissioning bodies and things like the Accelerated Access Collaborative is that in itself is not enough. We do need to have this hybrid about what actually works for populations, because, and I know from my own experience editing a journal for 16 years, the evidence that we collect from RCTs doesn't necessarily reflect the populations that we're dealing with in real life, and that then leads to lack of uptake of innovation and lack of sustainability. Companies like this are reaching out to us, and we linked them up with one of our population-based test beds, which were funded through NHS England, to look at how you can introduce innovation into real life populations and start to demonstrate that you can start using that and that it still works. Similarly, with a company called Respirisense that we've supported through one of our innovation accelerators that the 15 HSNs run that UCL Partners hosts. They were keen to take an important area around patient safety and work with a variety of trusts, both some of the big academic medical centres like UCLH, but some of the smaller centres, to think, is this something that really can help identify and treat a significant problem, and then how does that fit in to other things that hospitals are collecting. So we're running this across a group of hospitals within UCL Partners. The opportunity to work in the research space and link to the right patient groups and to stratify patient groups, I think is a remarkable opportunity. And we supported, and actually this was an SBRI funded program, to essentially take what was a paper system where someone was coming into clinic and letting them know about 2 or 3 trials that might be happening at UCLH, to a digital platform that could link them with all of the studies across the United Kingdom. And so we've been able to scale that so that this now essentially recruits a quarter of all dementia patients into research studies in the UK. And what we want to do is both to take this methodology around that matching process to other diseases, but also to look at other areas. Why can't you use that methodology to match patients to the right innovations that are available nationally and across the world? We set up, about 5 or 6 years ago, we set up a collaboration with what then was Quintel's, now IQVIA, one of the contract research organisations. And in fact, that was one of the outputs from the second sector deal, where IQVIA have invested 165 million into the north of England. I mean, it does seem sometimes if you've got north of England or Manchester in your title, then that you can't do anything wrong. But and that's great. Manchester and North England is great, but there is a need for us, I think, within the Golden Triangle to demonstrate that we can do quality work, that we can spread out beyond our domains. And so we're working, and we have this prime site around commercial trial recruitment. And what's nice about this is, so we have about 20 NHS trust partners. So as they recruit patients into commercial trials, the benefit is coming back into the organisations. But what we are now starting to do, because when IQVIA essentially repivoted as a business model, they now, to some extent, are a data analytics company. How can we start to use the data analytics that's been collected through the trials to start to inform around patient pathways and improving patient outcomes? So we're now working with them on a couple of trial sites around that, which I think has the great benefit of combining that real-world evidence and trial data. So I think that it's a big space. It's exciting. It's a great time to be in this area because there's so much to do. Data and making sure that we use data better, actioning it in the right way is fundamental. I do think we do have a responsibility, particularly in centres like this, around the research agenda, but both in terms and I think there is still very much a space for large centre trials, that very much. But what are we doing in the space about developing new trial methodologies? I mean, everyone talks about the Salford Lung study, which worked out at a cost of about £30,000 per patient, and actually, when you start to look at the data, it's not making an awful lot of difference. Who's taking responsibility for developing these new things that allow things to happen faster and quicker and more efficiently and effectively? And I think the people in this room should be the answer to that. It's us that have to do these things, but we just need to have agreement to then go ahead and do it. So thank you very much.
Thanks very much for that. Okay, we've got a few minutes to take some questions. There was a hell of a lot of material in there, a hell of a lot of lessons for us in Cambridge, I think, in terms of the way we organise. But we have some microphones wandering around. Who would like to go first? I was going to just check live first, then go to Slido after that, if that's okay. Because if we're all a bunch of shrinking violets, I'll have to go straight to Slido. Karen.
Hi. So actually, I put it on Slido as well, but I won't be shrinking Violet. So the question I had was around how will you assess the economic impact of the IQVIA Prime site? So will you be looking at workforce attraction, how many more clinical trials you can get? What does that assessment look like, and how can you share that?
Yeah, that's a good point. And we haven't done that. It's a very good question. I mean, and interestingly, I guess we've sort of been slightly galvanized by, their decision to expand into, another area and put significant investment into it. So I think you're right. I mean, it raises the question that I made in other points about the necessity of providing the evidence about what we're doing, because I mean, I don't know about you. So in our structure, we have a reporting system where through the Commercial Studies and Clinical Research Network, we report that into a board where our chief execs sit. So we sort of hold their feet to the fire around the data collection. But the frustrating thing is that it's often just about the numbers of recruitment. We're not asking the important questions about, and so what's the other benefits to this, both in workforce economically and in the translational side. So the answer to the question is we're not doing that for IQVIA, but I think it's a very legitimate question. And as we refresh our exec board, I'll take that question back to them. Thanks for that.
Janice?
It was me, yes. I was interested in the slide where you were talking about the kind of SMEs and the project with the Israeli entrepreneurs, because I do a lot of work. I've got a health service background, but I do a lot of work with life sciences and like around the various parks around Cambridge, very small, growing rapidly, and they're just finding it very, very difficult to understand. And although we've got the HSN has got so much to do that they're just invisible to these very small companies. So have you got any answers from your experience as to how I could help them broker that relationship really with the NHS? Well, one company in particular who have developed a product for post-cataract surgery that automatically gives kind of antibiotics. They're trialling out with vets and on animals because they can't get the patients and to access the kind of trials.
Yeah. I mean, I think, so our approach to that was, because I think, the HSNs to some extent were set up to do this, but it's taken them a while to get their act together to be able to have the capacity to deal with, the multiple approaches that they get. Actually, what the investment from Office of Life Sciences has allowed us to do is to be much more systematic about how we can deal with that. So actually, we've been challenged in the last year or two about setting up much more systematic platforms that support that. We took the approach, and I don't think it doesn't meet everyone's needs, but when we set up the NHS Innovation Accelerator about 3 or 4 years ago, what we found was, because there was a remarkable amount of interest around that, not everyone can get onto the programme. I mean, we elected for that programme to set quite a high bar because we wanted it to be quite mature products that were potentially ready to scale. We're not far off it. And that's been quite successful. But actually, both through the selection process, you can be very helpful to people, because when you sit down and talk to these companies, it is quite surprising that some of the advice that they need can be dealt with quite simply. So sometimes it's a catharsis. They just want someone to talk to that understands their problems. And sometimes it's a very easy signposting things. For others, we've found linkage to the thing I was talking about, evidence generation is really, really helpful. The Digital Health London one is now set up a number of streams where we're linking them to venture capitalists. So for the smaller ones, we're helping them with early funding. And I think, and I would hope Stephen Pearce would both agree with me, I think the HSNs are now much more mature, that approaching them is much more likely to be beneficial to them now.
Down here, Peter.
Hi, thanks for that talk. You mentioned a few companies there, Sleepio, Respasense, and others that are doing remote sensors, remote monitoring, remote technology. As these systems scale, you've got two axes. You've got increased provenance, security, quality of data on one scale, but you've also got on the other scale, speed of being able to integrate those systems into trials, into pathways. When you compare the speed of integrating those systems into UK-based systems with that is happening in Boston and Singapore and China that you mentioned yourself as competition, where are we at the moment, both I think UCL partners and Cambridge, if you like, and where do we need to get to be competitive in this emerging market?
If I'm being honest, I think we're slow. We're lamentably slow. I mean, the nature of these talks often show things that are working well, but we have examples of companies that have come to us. In fact, the Israel connection is quite a good example. The company, one of the reasons we started exploring that was we were approached by a company called Healthy.io that had a product that could, what's multiple functionality, but it uses any smartphone camera technology to look at urine samples by taking a photograph and using color sensitivities. And they're using it for detection of chronic kidney disease, for urinary tract infections, now moving into wound care. They have struggled so much to integrate that into the NHS because what happens is you have one conversation and that's where it stops. So it might work for that organisation, but no one then says, well, it's worked there. So where's the fast track that then gets that into 20, 30, 100 organisations? And so what these companies do is that they then start exploring other markets, going direct to consumers, for example, which a number of companies. And then when that happens, that then acts as the catalyst where the NHS almost feels embarrassed because they recognise they're being sidestepped. And there are probably many reasons why the states are better at that than we are. I mean, I think it's interesting. There's quite a number of American healthcare systems that are starting to move into the UK. So we've got Cleveland Clinic, for example, setting up in London. And what I'm quite keen to explore is how we use their learning and expertise, where they've been doing it much faster, to really accelerate that in the UK. Because the short answer is we're poor. You can sometimes get people who can do it quite fast in a disruptive way. And I mean, obviously the one that has been very visible is Babylon Health, which has gone around this essentially where they've done things quickly and not really asked for much permission about it. And there are pros and cons to that, but the good side of it is it does make things happen faster because the system then has to start responding to it.
Okay, I think what we'll do is, if there are no more hands, we'll just pick one from these. We've touched a bit on uptake. I suspect we'll come back to tribalism when we have the panel discussion, but there's one at the top here, which I think you're probably better placed than most of the rest of us, given the complexity or the number of organisations you actually take into yours, Charlie. Can the numerous networks actually end up hindering development if there are too many layers to prevent academia, industry and academia reaching their goal? Is it a bit difficult to work on?
I don't think so. There was a slide I had that you took out, which was so. In fact, I could just leave it at that and say those. Yeah. But and it's the progression for how things work in healthcare, and I think we've rapidly moved from a situation where we were dominated by markets and hierarchies to the effectiveness of networks. And I think networks are the answer. I passionately believe that. Of course, they won't get everything right, and getting a network to work efficiently is really difficult and involves a lot of real trust, actually, and being prepared not always to be the top dog or get the credit for it. But I don't see that as a problem. I see it as the opposite of that. I think networks are the answer to this.
Okay. All right, well, there you go. Charlie's not only given us value for money out of the slides he showed us, but also value for money out of the slides I didn't let him show you. So quite a feat. Can I ask you to put your hands again?